Today we are going to discuss about the second lecture of renin angiotensin aldosterone system. In the previous lecture we have discussed that how the renin is produced from the kidney and under what influences does the renin is produced. So let's revise according to this diagram that under the pressure reduction inside the systemic circulation, renin is triggered, and under the influence of the sympathetic nervous system, renin is triggered, and in response to the low sodium levels reaching the macula densa cells, the renin is triggered. And once the renin is triggered, it is converted into angiotensin 1. Basically, renin helps the angiotensinogen to convert into angiotensin 1, which flows along the pulmonary circulation to be converted into angiotensin 2. And in this lecture we are going to discuss about the effects of angiotensin 2 on the circulatory system. First of all, we need to understand that angiotensin 2 is a vasoconstrictor, okay? And the receptors for the angiotensin 2 are located on the smooth muscle cells of the arterioles and venules both. And when the angiotensin 2 binds on these arterioles and venules, they bring about certain changes, right? We will discuss venules first and then we will go towards the arterioles. First of all, when angiotensin 2 binds to the receptors, it causes the venules to constrict. As you know that 70% of the blood volume is contained in the veins, and that's why we call the veins as the capacitance vessels, because they have high capacity to contain the blood. It means that when the venules are constricted, it means that the pressure inside the vein starts to increase. When the pressure in the vein starts to increase, it will cause greater blood return to the right heart. First of all, what was our problem? Our scenario or our problem was that the patient is suffering from hypovolemia or shock or hypotension due to bleeding or maybe several conditions such as diarrhea. So his or her blood pressure is dropping, the both systolic blood pressure and diastolic blood pressure. We need to normalize the both diastolic and systolic pressure equally. So how we gonna do that? That's why we are learning that the effect of angiotensin 2 on the circulatory system. So let's continue. Pressure within the veins rises, it will cause greater blood return to the right heart. When there is right heart greater blood return, it means that it will cause increased cardiac filling. The cardiac filling will be more, and it means that the ventricles are filled more. It will cause increase in end diastolic volume and end diastolic pressure. The pressure and volume in the ventricles has been increased. It will cause the ventricles to stretch. What's the Frank-Starling law states? It states that under physiological limits, when you stretch the myocardial cells more, the more they will contract. It means that due to the increased cardiac filling, the left ventricle was stretched more. It means that it will eventually contract with a stronger force. Heart preload. What does preload mean? Preload means that amount of blood that is present inside the left ventricle that needs to be contracted. Okay. The preload of the heart is increased due to the increased cardiac filling, due to increased venous return, due to venule constriction, right? We are moving in the opposite direction. The more the blood in the ventricle it stretches more, the stronger the contraction according to the Frank-Starling law, higher will be the stroke volume and higher will be the cardiac output. And when the cardiac output is increased, automatically the systolic blood pressure is going to rise. That's our first target, right? We need to increase the systolic blood pressure. And the second target is to increase the diastolic blood pressure. How we have increased systolic blood pressure? Again, let's see on this diagram. Let's follow the theory that we have read, right? So first of all, we have constricted the venules. We have constricted the venules because the receptors for the angiotensin 2 are present on the smooth muscle cells of the venules. It will cause increased venous return towards the right heart, okay, and along the lungs, eventually towards the left heart. In the left heart, the cardiac filling is more because there is more venous return. It will cause increase in the stroke volume because the ventricles are stretching more, they will contract more according to Frank's Starling law. And when the stroke volume is more, the cardiac output will be more. And when the cardiac output is more, it will eventually cause the systolic blood pressure to rise. And that's what we need. We need systolic blood pressure to rise because the patient was suffering from hypotension. There was low blood pressure. So, how are we gonna increase the diastolic blood pressure? Stay focused that during systole, angiotensin 2 acts on the smooth muscle cells of arterioles. Okay, it means that this side of the arterioles is going to constrict. It will cause constriction of the arterioles. What does it mean? See, normally during diastole, the blood move towards the capillary and the venule side. Okay, the blood move here from the arterioles towards the capillaries towards the venules. If arteries are too open, it means that most of the blood will rush forward, causing the diastolic pressure to drop. When arterioles are dilated, it means that in case of low blood pressure, when the arterioles are dilated, the blood will move from arterial side towards the venous side. It means that the diastolic pressure will automatically drop. But if we cause the arterioles to constrict, on the effect of angiotensin 2, we have constricted the arterioles. When arterioles are constricted, what do you mean? During the diastole, during the diastole, it will cause the blood retention on the arterial side. Emptying into the vein is reduced. The blood and emptying into the vein is reduced. Originally, when the arteries were wide open, it will cause the blood to flow from the arterial side towards the capillary and venule side. But under the effect of angiotensin 2, when arterioles are constricted, they will cause the blood retention on the arterial side. It will cause increased pressure in the arterial system and it will cause increased diastolic pressure. And this all process is occurring in the process of diastole. That's why we call it as diastolic pressure. Okay, let's revise it. First of all, normally during the diastole, when the heart relaxes for a brief period of time, the blood rushes towards the capillaries and venules. It will cause the diastolic blood pressure to drop. But under the action of angiotensin 2, arterioles are constricted, the blood will retain on the arterial side, increasing the pressure on the arterial system during the diastole. Okay, and it will cause increase in the diastolic pressure, and that's our target number 2. Our first target was to increase the systolic pressure, and our second target was to increase the diastolic pressure, and we have achieved both. Moving on towards the action of aldosterone. What is aldosterone? It is a mineralocorticoid hormone. It is produced from the adrenal cortex under the influence of angiotensin 2. Basically, our main purpose is to increase the blood pressure in all the ways. Okay, we have constricted the arterioles, we have constricted the venules, right? Now we are going to see the action of aldosterone on the principal cells of the nephron. This is the like the cortical collecting tubule or the distal convoluted tubule because principal cells are present all the way in the cortical part and in the collecting part. Cortical collecting tubule and the medullary collecting tubules. It's the typical principal cell. It has sodium potassium ATPase on the basolateral membrane. It has sodium pump and potassium pump on the luminal membrane. Under the influence of aldosterone, what is going to happen? First of all, aldosterone is a mineralocorticoid. Its receptors are located inside the cytoplasm. Okay, The receptor will stimulate the nucleus. Inside the nucleus, there are genes. Genes for these transporters, genes for sodium potassium ATPase, genes for sodium channel, genes for potassium channel. It will upregulate the gene, it will cause more transcription, more translation, eventually more the sodium channels, more potassium channels, and more sodium potassium ATPase will be installed on the membranes. What will it cause? It will cause increased sodium outflow from the cell. It will cause increased potassium gaining into the cell. Eventually, it will cause increased sodium reabsorption. It will cause increased potassium excretion, and along with the sodium, who follows? Water follows. So sodium and water will be retained. It will cause the retention of sodium and water, and that's what we need. We need to increase the blood volume in case of hypovolemia and hypotension. That's why under the action of aldosterone we are going to retain the water and sodium under the influence of aldosterone, right? And when the sodium and water are retained in the principal cell, it will cause increase in the blood volume. And that's the same story. It will cause increase in the ventricular filling, higher ventricular contractility, higher stroke volume, higher cardiac output, and increase in the systolic blood pressure. Let's revise it. Under the influence of angiotensin 2, the venules will constrict, it will cause increase in systolic blood pressure, and arterioles will constrict, it will cause increase in diastolic blood pressure, and adrenal cortex is stimulated to release aldosterone, it will cause increase in the blood volume due to the retention of sodium and water. Again, there is an other important hormone known as anti-diuretic hormone, and anti-diuretic hormone is to prevent the water loss in the last part of nephron, and that's what exactly we need in case of hypovolemia. In case of hypotension, we need to conserve water in order not to lose the water, right? It means that angiotensin 2 interact with hypothalamus. As you know that ADH, the anti-diuretic hormone, is produced in the hypothalamus. It reaches the posterior pituitary via the hypothalamus, posterior pituitary hypophyseal tract, right? And they are stored in the posterior pituitary in form of vesicles. When there is sudden drop in the blood pressure, it will cause the posterior pituitary to release the stored ADH into the blood. And what this ADH will do, it will cause water reabsorption in the last part of nephron, and we have discussed it plenty of detail in the previous lectures how it's going to work. It will cause the installment of aquaporins on the luminal membrane. It will cause the reabsorption of water, right? So it causes the concentrated urine because water has been reabsorbed from the last part of nephron. The other thing angiotensin does, it will cause sympathetic nervous system stimulation. It means that receptors for angiotensin 2 are present in the sympathetic nervous system, and there will be increase in the sympathetic outflow. Normally, the postganglionic nerve fibers, I will explain that these are the preganglionic nerve fibers and these are the postganglionic nerve fibers. And the postganglionic nerve fibers on the target tissue, they will release the norepinephrine and epinephrine. And epinephrine and norepinephrine, they work as the sympathetic nervous system stimulants, right? Norepinephrine, epinephrine, these are the stress hormones. Normally what happens is that when the postganglionic nerve fibers releases the norepinephrine, 80% of the norepinephrine is reabsorbed by the nerve endings itself. It means that under normal circumstances, not 100% of norepinephrine is released. About 80% is captured again. But under the influence of angiotensin 2, it will cause increases the release of norepinephrine and it will decreases the reuptake. It means that 80% which we were recapturing, it is inhibited by the angiotensin 2. And when the reuptake is decreased, it means that the greater amount of norepinephrine is present in the synapse. The second thing, angiotensin 2 increases the receptors on the target tissue. It means that, for example, this is a target tissue and it has two receptors for the norepinephrine, right? But under the influence of angiotensin 2, the concentration of receptors is going to increase. It means that it will become 4 or it will become 5, it will become 6. So the effect of the norepinephrine and epinephrine is going to be increased under the effect of angiotensin 2. Conclusion: under the effect of angiotensin 2, when sympathetic fire is there, it will cause the sympathetic outflow, stimulation of sympathetic ganglia, stimulation of sympathetic nerve endings, and increased responsiveness of the target tissue. It will all be under influence of angiotensin 2. And why we need sympathetic outflow? Because in case of low blood pressure, sympathetic nervous system causes vasoconstriction and helps to restore the normal blood pressure. Again, the same thing is written that sympathetic nervous system will cause the veins to constrict, arteries to constrict, the brain to trigger the receptors for thirst. It means that when the blood pressure is low or the patient is suffering from hypovolemia, in case of diarrhea, vomiting, burns, right? The patient will demand water. He or she will tell that I am thirsty because under the influence of sympathetic nervous system, the brain is triggered for the thirst receptors. He or she will demand water, right? Last but not the least is the chronic RAAS activation and pathology. What does it mean? It means that there are certain diseases or conditions in which the RAAS activation is chronically activated. RAAS is useful or favorable under a short period of circumstances low in case of acute blood pressure reduction, right? In case of acute hypotension, it means that for a short period of time, RAS will activate as a positive thing. But in case of chronic RAS activation, it will be a negative aspect to our body and it will cause pathology. Let's see how. Diseases like congestive heart failure, when the blood flow towards the kidney is constantly low because the heart is under the congestive heart failure. Okay, heart itself is suffering, so how it's gonna pump blood towards the kidney? Kidneys are receiving constant amount of low blood flow. It will cause the increased amount of renin production chronically. Chronically, renin is being produced. It will cause chronic activation of angiotensin 2, and under the influence of angiotensin 2, aldosterone is chronically produced in such patients with congestive heart failure. So, these hormones, the angiotensin 2 and aldosterone, they will affect the myocardial cells and the fibroblast. They will stimulate the production of proto-oncogenes, and proto-oncogenes are involved in the cell growth. They will cause pathological myocardial hypertrophy. This myocardial hypertrophy is not physiological in any case because this is occurring under the influence of chronic RAS activation, and it will be always pathological myocardial hypertrophy. Not only hypertrophy, but the excessive growth of connective tissue, the extracellular matrix, and the fibrotic connective tissue. Their growth will also be increased under the influence of fibroblast and angiotensin 2 and aldosterone. In all these conditions, it will cause the alteration in the geometry of the heart. Our normal physiological shape of the heart is going to change, and these changes collectively are termed as cardiac remodeling. Okay, these changes are known as cardiac remodeling because the heart has been changed into something new. It has been changed totally. It is due to increase in the workload on the heart. Okay, not only the heart, but blood vessels are not spared at all. Under the influence of angiotensin 12 aldosterone, the smooth muscle cells of the blood vessels are constantly constricting, right? They are undergoing constriction, vasoconstriction, so they will cause vasculopathies. They will cause pathological changes in the blood vessels. That's we term as vasculopathies. In the condition of cardiac remodeling or the alterations in the geometry of heart, we need the treatment. We need the treatment. It's compulsory. So, in your opinion, what is the like first approach for the treatment? The medications that will inhibit the angiotensin converting enzyme, because angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, right? So we need to inhibit the ACE activity. When activity is decreased, the production of angiotensin 2 is decreased and the production of aldosterone is decreased. And that's how we are going to treat the effect of angiotensin 2, by inhibiting the angiotensin converting enzyme. Next, the second medication is the angiotensin 2 receptor blockers. When angiotensin 2 has been produced, we will block those receptors on which it works, right? And by blocking those receptors on which the angiotensin work, we can inhibit the effect of angiotensin 2. We can prevent the cardiac remodeling. Many important drugs are used in this class, but I will mention the most latest and the most, like you can say, of high importance. Alamandine. Okay, alamandine is derived from angiotensin A, i.e., Ang 1 to 7. Okay, it is derived from angiotensin A. It acts on the mass-related G protein coupled receptor D. You just need to remember that. The effect of alamandine is on the MRGD receptors. And originally, what was angiotensin doing? Angiotensin 2 was vasoconstricting, and in order to inhibit or oppose the action of angiotensin 2, we need something that causes vasodilation, right? And alamandine just do the job. It will cause vasodilation, and it will cause the cardiac protection. It will protect the heart from damage, including hypertrophy, cardiac remodeling, and dysfunction. That's what we need to treat it, right? Alamandine. Alamandine was act in the same way as the angiotensin converting enzyme inhibitors and the angiotensin 2 receptor blockers. It works in the same way as the traditional drugs do. They will cause the counteracting the effect of angiotensin 2 and exhibit the anti-inflammatory and anti-fibrotic properties. But alamandine is of great importance because it is like the latest drug, and it can be used in combination with the traditional drugs like ACE inhibitors and ARBs, angiotensin receptor blockers. But you need to remember some fancy name, that's alamandine. Okay, so this was for today. I hope you understand the concept behind the RAAS, and in the next lecture we are going to discuss about the acid base balance. So thank you for watching. I will see you in the next video. Till then,